Hi, I'm Dr. Ty Vincent. This is another video discussing LDI, low-dose immunotherapy, sort of. In this video, I'm going to talk about why I don't usually base any decisions on laboratory testing. I get a lot of questions about that. Most of the patients that I work with have been chronically ill for quite a while and have worked with many different doctors before they talk to me. And they almost all come with a stack of laboratory tests that cost them thousands and thousands of dollars, and yet they've ended up talking to me anyway, which suggests that those tests didn't really hold the answers for them. I have to specifically mention what kind of testing I'm talking about, because of course it's not all testing. I'm not talking about checking your cholesterol or your thyroid hormone levels or your blood count or your iron levels or anything like that. What I'm talking about specifically in regard to LDI is testing that is an attempt to figure out what kind of germs you're reacting to, what kind of microorganisms you might have in your body or in your gut, or that you might have antibody or immune reactions against, in hopes of figuring out what your problem is. That kind of testing is useless in terms of chronic inflammatory illnesses that are mediated by the immune system. Okay, what you're looking for is not an infection. And what you're testing with most of these methodologies is not clinical evidence that the symptoms the person has is connected to the organism you're testing for, if that makes any sense. For example, if someone has elevated antibodies to Epstein-Barr virus, which more than 95% of you do when I speak to you, that just means that either your immune system has seen that virus at some point in your past, even if it's an IgM level, okay? Your doctor will tell you if you have high IgM, that means you have recent or active infection. That's not true at all. That's a total misunderstanding. There are different kinds of antibodies, different ways to react. The IgM can show up positive and then negative, and it can go up and down every month, even though you've gotten the virus once and it hasn't ever left. So that's not even correct interpretation of the test. But basically, if you have those antibodies that are elevated to Epstein-Barr virus, it means you probably have the virus in your body already, because the vast majority of us do, or you've encountered it before, or you could be cross-reacting with something else. And that's one of the inherent problems with antibody tests in the first place, is that antibodies are not evidence of that thing being present. You can have a positive antibody to peanuts. Does that mean you have peanuts in your body? No, it doesn't. And you can have things cross-react in a very dramatic and bizarre fashion. There's evidence that Epstein-Barr virus, again, for example, cross-reacts with Borrelia and may cross-react with various other kinds of organisms. Borrelia is not even a virus, and Epstein-Barr virus is. So antibody-based testing in particular is fraught with errors and misunderstanding. Even if you do a culture, let's say you do a really expensive long-term blood culture and you show that you are growing Borrelia burgdorferi, or some other species in your blood. Does that mean you have Lyme disease? No, it absolutely does not. If you do dark field microscopy and you see corkscrew-shaped little creatures going around in your blood that look like spirochetes and might be Borrelia to one person and might be some other kind of spirochete to somebody else, that also doesn't mean you have Lyme disease. Because we know by doing those tests on lots and lots of people that completely healthy asymptomatic people will carry Borrelia, will carry Bartonella, will carry all kinds of organisms. Even like if you look at tuberculosis, only 10% of people that have been infected or colonized with a tuberculosis bacteria will ever actually get clinical tuberculosis. 90% of them, it'll stay dormant or inert in their body until they die of some other thing. So tests that prove the person carries an organism doesn't mean they have a disease associated with that organism, unless it's one of the rare organisms that always causes disease, and those are very few. I mean, syphilis might be one of those, and we don't see that very often. But even, like I said, tuberculosis, having the organism in your body doesn't guarantee you have a disease associated with it. Ebola virus is another example where we thought anybody who got that would get Ebola and die, right? And now we know that in endemic regions, up to 60% of people have positive antibody tests for Ebola, suggesting that they got it and didn't die. So all of these tests are indirect evidence, and none of them are direct evidence. And what we need is direct evidence. So the people that I work with tend to have heightened immune response reaction problems in general. So what that means is that you will probably have elevated antibody levels to a whole slew of different things. adenovirus, Coxsackie virus, all these different strains of it, Epstein Barr, cytomegalovirus, HHV6, you know, high levels to Borrelia, positive Western blot or not. None of it matters. None of it correlates with your symptoms. I see it all the time. And the biggest danger of doing that kind of testing and making decisions based upon it is that it causes the doctor to impose treatment options on the person that they do not need and that may cause significant harm, most commonly antibiotics, you know, or some other thing to kill germs in your body. And they often lean on things that are indiscriminate killing, like 4 different antibiotics at the same time, or high doses of ozone, or hyperthermia, you know, some other thing. And that's a problem. And then by the time I get those people who have been treated in that manner, they're often a lot sicker than they would have been if I had gotten to treat them before they were given the onslaught of antibiotics. So this is the issue I'm talking about when I tell people I don't want your laboratory tests. There are certain laboratory tests involving microbes that are occasionally helpful. One is like an anti-streptolysin O antibody, so the strep antibody in a person you think might have pandas. That can be helpful, but pandas is such a specific set of symptoms anyway that if you needed an antibody to tell you the person had pandas, you probably shouldn't be practicing medicine, honestly. So it's not even a necessary test clinically, but it can often, you know, indicate that that person does have a reaction to strep. The problem is that the symptoms of pandas can be caused by other things also: foods, herpes simplex virus, parasites. So even if they did have an elevated ASO, it doesn't necessarily mean that that is causing the OCD and the anxiety and the tics, all right? It all comes down to clinical discussion. The way you make these decisions well and the way you treat people effectively is to talk to them for a very long time, to get a lot of answers to a lot of complicated questions. I ask people questions in a way that they're not used to, or I ask questions that they've never been asked before, because the information I need, I have learned over the years, is different from the way we tended to ask questions before. The specifics of your symptoms, when they happened, in association with other events, those are things that link your symptoms and your clinical condition to an organism, you know, based on suspicion. For example, if you have a child who had strep throat every 3 months from age 1 to age 5, and then finally had their tonsils out, and then the next time they encountered strep, they developed OCD and tics and anxiety, couldn't leave their house. That's a typical pandas kind of story. I don't need a laboratory test to tell me, let's try the strep antigen in that kid and see if it works, okay? If the same symptoms exist in a kid who they say has never had a case of strep throat in his life, but he did have colic, ear infections, eczema, and then he got some random viral seeming illness and he developed OCD and tics and anxiety, that's probably a kid who has food allergies that are causing those symptoms, not strep. Okay? This isn't complicated. You just have to take the time to ask all the right questions. And even after that, even asking all the right questions, getting the answers, having laboratory testing done if you choose, you still don't know for sure what the problem is for that person until you try it. So you try strep in the same context we're talking about. Try strep, see if it works or it doesn't. You try food, see if it works or it doesn't. You figure it out. You figure it out by specific antigen trial and error. If I have somebody with Crohn's disease can be linked to a half a dozen different antigens in my experience. Foods, yeast, mycobacteria, parasites, okay, maybe not quite a half a dozen, but close. H. pylori. There are some various things in the gut that might do it. I have Campylobacter. Sometimes I have to desensitize people with inflammatory bowel disease using a sample of their own stool. And I have no idea what they're reacting to. So there are many possibilities. No matter what kind of testing you run on that person, no matter how many questions you ask, you still won't know what the triggers are until you get into it and you start experimentally giving them different antigens and you see what they do and do not react to. And a lot of these conditions I work with are multifactorial. It's not one thing. Crohn's disease is hardly ever one thing. It's usually on average 3 or 4 things that you've reacted to in the gut at the point I get a hold of people. It may start with one thing, and then the nature of people with inflammatory immune illnesses is that they collect targets. They start reacting to more and more things. So we have to figure it out. And again, the testing does not get you there. Another kind of testing to specifically mention is stool analysis. The people I work with do not have infections. They may have what you call dysbiosis, but that's a very general term that leads you nowhere in terms of intervention. What the fact is for most of these people that have an inflammatory reaction to some gut organism is that their immune system is killing it. And so when you do a stool analysis, you don't see it. The best example I have, the most common example, is yeast. I have people that have horrific hypersensitivity reactions to the yeast organisms, to candida. And when you do a stool analysis on them, there's no yeast, or there's very low levels of yeast. And then their doctor gets extremely confused because they were sure you had a yeast problem. And they give you an antifungal and you get better temporarily, but when they stop giving it to you, your symptoms just rebound within 2 or 3 days. That's really all the evidence you need to tell me to know that that person has a yeast sensitivity problem. What confuses the doctor is then they try to verify their suspicion with a stool test, expecting to see yeast because they think it's an infection, and it's not there. Well, what that tells you is it confirms that the mechanism behind this illness is yeast allergy or yeast hypersensitivity. And when that happens, you do not see it in the stool. So I get people with gut symptoms all the time, clearly inflammatory gut symptoms, and they tell me, here's my stool analysis result. And I'm like, well, that'll only show me everything that is not the answer. The things that your body still tolerates living in your gut are not the thing that your gut is trying to kill, obviously. So it's like a photo negative of what you're looking for. So stool analysis in particular in the setting of these illnesses is not helpful. And it just leads you to the wrong kinds of treatment in most cases. There are some examples with immune issues where I do track laboratory values. Hashimoto's thyroiditis, I give people the Yersinia antigen and I track their TPO antibody. People with myositis, polymyositis, I give them either Lyme or stool or whatever seems appropriate for their case, usually those two things, and I track their CPK enzyme. So there are cases where a laboratory test is worth tracking. Those are very uncommon in my practice. And basically the whole point of this was to explain to people in a little bit more detail why this mountain of thousands of dollars worth of laboratory testing you have isn't necessarily going to help us and isn't usually something I want to see. There'll be more to come, maybe not specifically on this subject, but we're going to try to do videos more often so that people get a little more information here and there on various topics. Thanks.